All right, I think we can start. Good afternoon, everyone. Good afternoon. At least in Africa, you have to respond. Good afternoon. Yes, thank you for choosing to attend this session. It's an oral poster session on mortality trends in the era of ART. My name is Dr. Lucy Nganga. I work for CDC Kenya, and I'll be chairing this session. We had a total of 6 oral poster presentations, but one of us is missing. Has he come? Maybe he'll be joining us in the course of time. Each presentation will be 5 minutes, and we kindly request the speakers to keep to the time, and we'll alert you if you run over time, and maybe stop you. I hope not. Now that one is not there, you may have a benefit of an extra 1 minute. I think we'll allow all the speakers to present, and then we'll have time for Q&A. And thank you and welcome. So our first speaker is, I hope I'll pronounce your name correctly, is Margarine. Perfect, all right. She will present on mortality differences after ART initiation in HIV-positive women from Europe, the Americas, and Sub-Saharan Africa from 2000 to 2014. Inma is a senior researcher and a statistician at the unit of the cohort of the Spanish AIDS Research Network. Welcome.
Thank you very much. Women account for nearly half of persons living with HIV worldwide. In this work, we focused on those HIV-positive women and aim to estimate all-cause mortality after ART initiation and by duration of ART use among women living with HIV in Europe, the Americas, and Sub-Saharan Africa up to 48 months after ART initiation. To answer this objective, we merged databases from HIV observational cohorts participating in 2 international collaborations, IDEA and COHERE in EuroCord. We included antiretroviral naive women infected through injected drug use or sex between men and women, aged 18 years or more at ART initiation, who started ART between 2000 and 2014. It is important to mention that only women from North America were required to have a second visit within 12 months after enrollment. To assess the impact of under-ascertainment of mortality in our results, we asked for IP investigators about the quality of their mortality data, and cohort linkages with mortality registers were reported in South Africa, North America, South America, and some sites in Europe. Systematic sample tracing of losses to follow-up was conducted in East Africa, and then we applied weights to correct underreporting of mortality. And mortality ascertainment data from East Africa were used to correct under-ascertainment in West Africa using inflation factors. Data contributing regions were categorized as Europe, East Africa, West Africa, South Africa, South America, North America, and Central America and the Caribbean. We calculated mortality rates by region at different intervals after ART initiation. And we also calculated adjusted mortality rate ratios at each interval compared to Europe using piecewise exponential parametric survival model fit through Poisson regression. We included 190,175 women, most 47% from East Africa, 19% South Africa, 16% from Europe, 13% from West Africa, 3% from North America, 2% from Central America and the Caribbean, and 1% from South America. Age at ART initiation ranged from 33 years in South Africa to 40 years in North America. The proportion of injecting drug users was highest in North America at 18% and in Europe, 7%. The proportion of women from Black race ethnicity was higher in North America, 63% than in Europe, only 26%. And the CD4 T cell counts at ART initiation was close to 250 in Europe and North America, 141 in South Africa, and between 170 and 190 in other regions. Here you have, in this figure, the crude mortality rates per 1,000 person years. And as you can see, mortality rates during the first 3 months after ART initiation were the highest, except in women from North America due to cohort eligibility criteria, to decline thereafter. Mortality rates in women from North America in purple color were slightly or were stable during the whole period, and mortality rates in women from Europe in light blue color were the lowest during the whole period. Here you have the adjusted mortality rate ratios compared to Europe, and although it is true that after adjustment for age, CD4 T cell counts, and period of ART initiation, differences were slightly reduced, what we can observe is quite similar to that observed in the figure. Women from Europe show the lowest mortality rates during the whole period, with the greatest differences between regions in the first 3 months to attenuated thereafter. So to conclude, we have shown global variations in all-cause mortality in HIV-positive women initiating ART, showing distinct geographical patterns for short and long-term mortality that may inform context-specific interventions. We have shown highest mortality in women living in Central America and the Caribbean and Sub-Saharan Africa, and the lowest in Europe. And we have found highest mortality in the first 3 months in all regions, except for North America, decreasing from then onwards to reach stable rates from the first until the 4th year following ART, where interregional differences become less remarkable. And my last slide, to acknowledge IDEA and COHEAR in Eurocore for letting me do this work. Thank you very much.
Our next presenter is Alison Carter. Alison will present on high mortality among women living with HIV enrolled in Canada's largest community-based cohort study. Alison Carter's current doctoral research focuses on understanding positive aspects of sexuality for women living with HIV in socio, relational, and structural contexts through various feminist theoretical lenses and quantitative techniques. Welcome, Alison.
Good afternoon, everyone. I have no conflicts of interest to disclose, and I want to thank and acknowledge the women living with HIV, our partners, communities, and organizations, and many individuals who make CHIVOS possible. This research was conducted in response to a call from action from women living with HIV in Canada. We're aware that the findings may be particularly difficult to hear, as many in the room have lost family and friends over the last several years, and we want to honor and remember the women who've passed away in our study, and we present these findings in their memory. With treatment, people living with HIV have life expectancies similar to that of the general population. A recent Canadian analysis, however, found that female patients have significantly lower life expectancy than males. These data highlight inequities by sex, but there's limited data on other aspects of women's lives that may predict higher mortality. The objectives of this analysis were among women living with HIV in Canada to measure crude all-cause mortality, to compare the age-standardized mortality of women with HIV in our study, CHIVOS, to that of the Canadian female population, to assess cause of death, and to identify predictors of mortality. We used data from CHIVOS, which is Canada's largest community-based cohort study of women living with HIV. Participants complete a peer-administered survey at baseline and then every 18 months of follow-up. And in this analysis, we included all 1,422 women who were enrolled at baseline across 3 provinces, British Columbia, Ontario, and Quebec, in blue. Death and cause of death were determined via study follow-up procedures. This was primarily through notification to our coordinators and study staff from peer research associates, family, friends, community agencies, and research partners. In BC, we were able to confirm these deaths via linkage to vital statistics data. To calculate time at risk of death, we sum the months between the participants' enrollment in the study and then their end date, which could either be death, withdrawal, complete at wave 3, loss to follow-up, decline wave 3, or December 1st, 2017, the time of this analysis. The total cohort time at risk was then summed across all participants and measured and expressed as women years of follow-up. In terms of analyses, we conducted an age-standardized mortality ratio. We computed that using 2011 data from Statistics Canada of the Canadian female population, and we conducted a proportional subdistribution hazards model to identify unadjusted and adjusted factors associated with mortality over the follow-up period. Because loss to follow-up can be associated with mortality, these participants were retained in our analysis and measured as assumed to be still at risk of mortality. So at baseline, the median age of women in our cohort was 42. 45% of women were currently or previously using drugs, and most women were engaged in care, on treatment, and had an undetectable viral load. Over the follow-up period, 54 women had died, which is 4% of our cohort. The crude mortality rate was 11.8 per 1,000 women years, and the age-standardized mortality rate in our study was 4.5 times higher than that of the Canadian female population. The primary cause of death was unknown in most circumstances. When it was known, the leading causes included cancer and cardiovascular disease and drug and alcohol use. In unadjusted models, several social and structural factors were significantly associated with mortality. In the adjusted models, independent predictors of mortality included hazardous alcohol use, tobacco use, and depressive symptoms. No HIV treatment markers were associated with mortality. We found an alarmingly high rate of mortality in Canada's largest cohort of women living with HIV in Canada, women who are primarily engaged in care and on treatment. No HIV-related clinical factors predicted mortality. Instead, comorbidities, substance use, and mental health presented greater risk to survival. These data suggest that to prevent premature mortality among women, good HIV clinical care is not enough. There's an urgent need for women-centered HIV care, including community outreach services, social care services, and policies that are specific to harm reduction and involve and prioritize peer leadership and support. Thank you.
Thank you so much, Alison. Our third presenter is from South Africa. Her name is Victoria Pillay. Victoria is an infectious disease epidemiologist with formal training in evidence-based healthcare and is the Deputy Director of the Burden of Disease Research Unit at the South African Medical Research Council. Victoria will present to us tracking trends in HIV/AIDS mortality pre- and post-ART South Africa from 1997 to 2012. Thank you. Welcome.
Thank you. Good afternoon. Today I'm going to share with you findings of HIV/AIDS mortality trends pre and post the antiretroviral treatment rollout in South Africa using data from our second national burden of disease study. So South Africa has one of the most extensive antiretroviral treatment rollouts in sub-Saharan Africa, and our program was rolled out in 2005. The country also has a vital registration system that routinely collects cause of death data for the country. However, due to the stigma in South Africa, doctors don't certify HIV as a cause of death. So what we did was we identified causes that the doctors actually attribute to these HIV deaths to, example, TB and diarrhea. We identified 19 such causes, and then we removed the HIV deaths from them and reallocated them to HIV. We also adjusted for other data deficiencies in the vital registration data. And after adjusting for misclassified AIDS deaths, we identified over 3 million deaths for our study period for South Africa. What you are looking at here is the number of deaths by age group for South Africa for the study period. And I would like to draw your attention to the brown bar at the bottom. And that brown bar is actually showing you the number of deaths that were actually recorded as HIV/AIDS deaths in the vital registration system. You can actually see that most of the deaths that we found were actually sitting in AIDS indicator conditions. For example, the blue bars, the dark blue bars, which indicate TB deaths, and the green bars, which are actually showing us diarrheal deaths. So we found in our burden of disease study that HIV was the leading cause of death throughout the study period. HIV/AIDS deaths were attributed to 14% of total deaths in 1997, 41% in 2006, and 29% in 2012. The rates peaked for women in 2005 and in 2006 for men. So this graph is basically showing you the death rates for HIV by males and females, males on the left-hand side and females on the right-hand side, by age group for 1997, 2000, 2006, and 2012. And we're using 2006 because that's just after the antiretroviral treatment rollout. And what you can see here is that in the 25 to 34-year-old age group, women had higher rates than males. However, from 45 years and older, you can actually see that the rates are much higher in males than it is in females. You can also see that for men here, we're looking at the 65-year-old plus, you can see that by 2012, men still had the same level of rates as it was in 2006. So not much has happened. So I just wanted to say that the black bar is 2012. It's the latest data point. And you can also see in this graph, the black line is indicating that for females, the rates had actually reached the same levels as rates in 2000. So there's been much improvement with women, and basically with men 45 years and older, we are seeing a challenge. So in conclusion, HIV is the leading cause of death in South Africa still, even though we've made some huge gains in the fight against the epidemic in the country. As you have seen, the number of deaths due to HIV is almost halved since the antiretroviral treatment rollout in 2006. However, our men, 45 years of age and older, still have high rates, and we are identifying them as a risk group and are actually recommending that treatment and prevention programs actually strategize ways to actually target men 45 years and older in the country. I would like to acknowledge the South African Burden of Disease research team, which is a large number of people, and flagship funding from the SAMRC to actually do this project, and partial funding from NRF to actually attend this conference. Thank you.
Thank you so much, Victoria. Our fourth presenter, at least we get to get a gentleman. Where are the men? We keep asking. All right, he's from Zimbabwe. His name is Tinei Shamu. He will present to us mortality trends among HIV-infected patients at Newlands Clinic in Harare, Zimbabwe. Tinei is a biomedical scientist, laboratory manager at the Newlands Clinic in Zimbabwe. Welcome.
Thank you very much. It's good to represent all the men. So we conducted a mortality study at Newlands Clinic in Harare, Zimbabwe. And by way of context, Newlands Clinic is an outpatient HIV management clinic that is currently looking after about 6,300 patients. And since the time that we have started HIV management in 2004, we have seen around 7,000 patients that have come and attended at least a single visit. So this was the inclusion criteria for our study. We included everyone that attended at least one clinic visit. So we conducted it as a retrospective study in which we grouped the causes of death according to two groups of communicable AIDS-related illness, malignancies, chronic non-communicable diseases, non-AIDS, and other. And in the other section, we included things like suicide, pulmonary embolism, accidents that could not be added to the other groups. And then we added these, the cause of death according to the year of death. So we grouped 2004 to 2009, 2010 to 2014, and 2015 to 2017. I would just like you to realize that that Newlands Clinic is a referral HIV management center, and this affects the inclusion criteria of patients who are enrolled at the clinic because the criteria changes over time. So this is the crude mortality rates from 2004 to 2017. You can see there was a sharp decline from 2004, which was around the time that the art program in Zimbabwe was initiated. And so by the time of 2017, the crude mortality rate had reduced to around 40 deaths per 100,000 per 100 person years, from as high as 354 per 100 person years. I don't expect you to read all the causes of mortality here, but what you're looking at in blue are the chronic non-communicable diseases, and in red are the communicable AIDS-related illnesses. Now, what you can observe is that over time, as you're moving from the left to the right, the red dominated the top 10 causes of death. But as we move to the right in 2010 to 2014 and 2015 to 2017, there is an increasing dominance of the non-communicable diseases, with renal disease becoming the second most common cause by 2015 to 2017. We also have malignancies. If you take note on 2015 to 2017, where it says other cancer, and right at the bottom, non-Hodgkin's lymphoma also became an important cause of death. It is also important to note that pulmonary TB has remained a significant cause of death from 2004 through to 2017, and with the relative proportions increasing to 10.8% in 2015 to 2017. This is an illustration of the proportions of contributing to the mortality over time by age groups. And what's important to note here is that at the beginning in the blue, which is the largest chunk of deaths, were in the 25 to 49 age group. But as we move towards 2017, we have an increasing relative proportion in the age groups of 19 to 24, as well as those that are above 50. What does this mean to us? This means that non-communicable diseases are becoming an important cause of death among HIV-infected patients, and not just communicable AIDS-related illnesses, although these remain dominant. And this is an important information for those that are making the policies to address these diseases in the countries. Also, it is important to note that the 19 to 24 age group is indeed a key population, and we're seeing more and more mortalities in this age group during this time. I thank you very much.
I can see people are already starting to doze. So maybe we can have one or two questions. We do have time. And then we can continue the rest of the speakers, the presenters. So I can welcome 2 or 3 questions, and then we'll, yes. Short and precise, yes. Is there a microphone? Yeah. Can have 2, and then we'll continue.
This renal deaths is because of the tenofovir related, or that is one thing. And second thing, that the age group is the highest death rate. Why that is the, what is the reason for that?
All right. Let's have the second question, and then we can respond. Yeah.
My name is Beatrice Stickers from KNCV Tuberculosis Foundation. I'm surprised to see in the statistics seen so far in the various studies, TB to be either not mentioned or just 10% of the causes of mortality, whereas we know it to be 40% of people living with HIV die due to lower due to TB. So it's a major cause of death. And I'm wondering what in the various studies is not raising this. And I think it has serious implications and reasons that we're not doing what we need to do to lower mortality amongst people living with HIV, because TB is there. Yeah.
All right. I think that question can be responded by anybody, but we can start with the one that was specific to Zimbabwe.
So regarding the question on whether the renal disease was due to tenofovir, it is difficult to say currently, but we do have multiple causes of renal disease, HIV, HIVAN being the most common cause, because in our study we note that 59% of all mortalities occur within the first year of treatment. And a lot of these patients are in fact patients who have just only started ART or were being prepared to start ART. So I can't definitively say that it is because of tenofovir, but I doubt that very much.
There was a second question on high mortality.
The reason why the middle age, the young adults who had the highest mortality is because the HIV epidemic itself is disproportionately higher within that age group. And from the time that that the ART rollout started in Zimbabwe, this was also, you remember the life expectancy was in fact 36, because this was the age group that was most affected by HIV. And this remains to be the case currently. I don't know if that answers your question.
In the era of HIV treatment, how that is possible?
Sorry.
All right, maybe we'll come to that after, yeah. So anyone can respond to the TB question?
Can I?
Yeah, please.
So what you saw in the slide that I showed you about the misattributed HIV/AIDS deaths, so 70% of TB deaths were actually HIV/AIDS, showing the co-infection. So 70% of the TB deaths in South Africa, we actually took and put into HIV because they were actually HIV positive. So we went through, we only had 5 minutes, so I went through it very quickly, but the TB-HIV association is strong in South Africa. I don't think this is on.
So maybe I wanted to ask the presentation from the first one, the Canadian one. Is it? No, the one that looked at data from various countries. I think it is you who did that. And the mortality being very high in East Africa and West Africa in the first 3 months. Was it related to TB?
Well, we did not have information on causes of death, neither on AIDS-defining diseases, but it is true that we observed very high mortality during the first 3 months, so we think it's obviously AIDS-related mortality. But this is the data we had. We did not have this information.
All right. If there is no other question, I think we'll continue. There is. Okay, sorry.
I just, not really a question. I have a clinic in Botswana, which is similar to Newlands, but much less, 2,000. And we also have a very, very high mortality with TB. But the problem is that it's so difficult to prove that it's TB in this setting. And I think that's why you have such low levels. We are picking it up by doing ultrasounds, cardiac ultrasounds, where you can see a very thick and large pericardial effusion, which we assume but can't prove is a TB, but then they get better when they're treated. So just a comment, sorry. And thank you all for your lovely presentation.
Okay, we'll have our fifth presenter. Our fifth presenter is Belén Alejos from Spain. He is a researcher. Oh, she. Oh, sorry. Oh, my God. sorry. Okay, so women. Good, powerful women. She is a researcher who focuses in the statistical analysis of longitudinal studies, in particular, complex analysis with multiple imputation methods, relative survival, and excess mortality modeling. Welcome.
Thank you. Thank you for the nice presentation, and thank you for the opportunity to present this work here. Hepatitis C co-infection is one of the leading comorbidities among people living with HIV. Therefore, our objective was to study trends from 2000 to 2014 in overall and cause-specific mortality stratified by hepatitis C co-infection among HIV-positive adults within the collaboration of observational HIV research in Europe, COHERE. For this study, we included HIV-positive adults from Western European countries older than 16 years and recruited after 2000, antiretroviral naive at baseline, and with at least one HCV antibody test result. Cohorts with more than 15 missing causes of death of hepatitis C test missing were excluded from this analysis. Baseline was defined as the date of cohort recruitment for subjects with known hepatitis C status at cohort entry, and as the date of the first hepatitis C test for subjects with unknown result at baseline. Our outcome was overall and cause-specific mortality. Cause-specific death groups were created based on a simplified version of the CODE coding algorithm. To assess trends over time, 2 calendar periods were created from 2000 to 2007 and from 2008 to 2014. We use multivariable Poisson regression to calculate adjusted mortality rate ratios for the effect of calendar period. And we present the analysis stratified by hepatitis C co-infection. In the upper part of the slide, we can see that from 2000 to 2014, approximately 74,000 subjects were included and 2,700 deaths were registered. 36 years old was the median age at entry, and 72% were males. 13% were hepatitis C positive at baseline. For hepatitis C negative subjects, the main route of HIV transmission was men who have sex with men, and for hepatitis C co-infected subjects, the main route was injected drug use. In the down part of the slide, we can see a graph with the causes of death distribution, stratified by hepatitis C co-infection and calendar period. For both periods and both groups, hepatitis C positive and negatives, the leading cause of death was HIV/AIDS, followed by non-AIDS defining malignancies among hepatitis C negative subjects, and followed in both periods by liver-related mortality among co-infected subjects. In this graph, we present the mortality rates per 100 person years of follow-up for stratified also by calendar period and hepatitis C co-infection. The lines in black are for co-infected subjects, and the lines in gray are for hepatitis C negative subjects. In the small blue boxes, we can see the adjusted mortality rate ratio for the effect of calendar period, taking as a reference the period 2000-2007. We detected higher mortality rates among co-infected hepatitis C co-infected subjects for overall, for almost every cause of death, excluding cardiovascular in the first period and external mortality. Regarding the trends, we observed decline in mortality for both groups, mono and co-infected subjects, for overall, HIV/AIDS, and non-AIDS infections. Regarding liver mortality, we also detected a significant decline in both groups. However, the relative decrease among non-hepatitis C co-infected subjects was more marked. In conclusions, hepatitis C co-infection is associated with increased overall and cause-specific mortality among HIV-positive patients, significant relative reductions in overall mortality, as well as AIDS, liver, and non-AIDS infection over time was observed for both mono and co-infected participants. Finally, I would like to thank all the COHERE participants and to my working group team.
Thank you. All right. Our last presenter will present on mortality and cause of death among HIV patients in London in 2016. Her name is Valerie Delpach from United Kingdom.
Thank you. Yeah,
all right,
that's
welcome. We were missing you. Thank you.
No.
Yes, she's a consultant HIV epidemiologist at the Public Health in England. Welcome.
Thank you very, very much. In context, I think what's important about this work is also, we've just seen some really interesting presentations around how we are now getting a better sense of death data, and it's so pleasing to see because, as we know, in many countries, the linking of death data with surveillance data is just non-existent. And if we don't have a good sense of why people are dying, and to hear that people are dying more of AIDS still in South Africa, for instance, is staggering. I mean, why is that still happening despite all the programs, etc.? So it is a really, really fundamental key marker, as we know, but we've been very privileged in a lot of countries where now death data is less important because we're seeing fewer people. And we, in a way, have just kept up looking at the numbers over the years and quite nicely show each year how they are fundamentally dropping. We produced a paper with the same lead author, Sarah, who couldn't be here today to present, the overall trends in deaths among people living with HIV in the United Kingdom, showing now that they have absolutely the same mortality rates as background population, and that's quite fundamental and extremely exciting. Nevertheless, people living with HIV are still more prone to premature death, particularly if they present late, clearly, and also because they often have other associated factors. And so this project in London is really very much led by clinicians who want to review very closely every single death in London among people living with HIV. And again, this is the partnership between epidemiologists, researchers, commissioners and clinicians looking very closely how they can improve their clinical practice and delivery of care. So in this project, it stems from linking epidemiological data to identify people who have died from the Office of National Statistics data, but also from clinicians reporting deaths over the year and looking in detail at the case study. Now, there's been a number of tools to do that, and the code reporting form is used extensively, but it's quite lengthy, so we abbreviated that to some degree to make it a little easier. But every single death, of which there have been about 200 each year, and now about 200 and 250, so it's a feasible audit to actually look at every single death and say, could we have done something differently to avoid this death? Very much led by the clinicians doing this. And the results from this poster for 2016 are similar to what we've been seeing in the last few years. Obviously, more men died because actually they're part of the larger older epidemic among gay men. It isn't a difference, we don't think, around why men dying more, but it's actually the cohort being larger among older gay men. And really, it was a way of trying to identify, one, is it completely preventable death? Is it late diagnosis we should have done something about? Yes, we continue to see about a quarter of late diagnosed individuals who are prematurely dying. We need to do something about that. What about the ones who are not dying of AIDS? What are they dying of? Are there things we could be doing better? And that's the introduction of a whole range of assessments and keeping up assessments around, for instance, smoking, looking at excessive alcohol use. And are we doing enough to prompt and understand? Because while we've been doing so well with HIV and doing exceedingly well at caring for HIV, we have really very subspecialized services, and now those services are being asked to also take on a far more well-being assessment of patients. So are we introducing the right types of things to screen people? Depression came up as a very significant, important problem, for instance. And these types of audits allow people to sit around and really discuss how we should really identify what could be unexpected deaths where there was no planning or an expectation of someone not doing well. Might have been a late presentation, someone who's dropped out of treatment. Could we have done something differently? How do we assess that? So really, rather than going into the detail of the results, which you can get from the poster, I wanted to convey more the process and how it leads to then reassessing how we might prevent further premature deaths or unexpected deaths. Thank you very much.
Thank you so much. We have 20 minutes for questions and answers or comments. Please feel free. Yes, we can.
Hi, thank you very much. Thank you for a wonderful and comprehensive presentation. One of the things that I'm making a point of trying to attend sessions regarding the idea of the missing men. I think that that's a theme that's emerging in this conference, and I think that that differential mortality data that you're presenting really continues to highlight what I think is a significant and emerging trend or awareness in this conference. It's a trend, I think, that we've been aware of for a long time. So I guess I'd love to hear your ideas about some of that, why you think there's that differential in mortality outcomes, and what you would then suggest may be done to address that. And then also, I think that we see this in general, not HIV specific, but I think that the burden of masculinity as it affects men themselves, I think that that's just something that perhaps the HIV culture and communities can really lead in. We've been groundbreakers in so many aspects of healthcare through the history of this epidemic. I think that addressing the burden of masculinity and health outcomes could be something that our culture could really lead the way on. So I'd appreciate your comments. Thanks.
Maybe we can just respond to that. Feel free to his question.
Is that my? I'm not sure if it was to me specifically.
No.
Clearly, we're almost women here on the panel, but so, I mean, it's been very, very encouraging to hear at this conference how we need models of care that attract men to attend for healthcare. I mean, that's the minimum, isn't it? And at present, you wonder what the healthcare, is it ready for anybody? Because we're trying to make it friendly for our key populations, trying to make friendly for women who might not feel comfortable, and equally men don't feel comfortable. So we do need to tailor how we present our services, and it was encouraging to see, men knowing that they can be examined and seen by other men, for instance, and know that that's something that's not necessarily a given, is working in some circumstances. You probably have more answers than I do around why men don't come forward and get tested and the missing men, and I'd love to hear from you rather than me trying to come up with some of those.
Maybe a comment from Zimbabwe.
Yes, so the idea of men coming for testing is a well-known challenge that we have faced in Zimbabwe, and if you were in the plenary, you will have noticed that the initiative that is coming through from the Duke and with Sir Elton John also targets or has some activity in Zimbabwe. In our study, some 2/3 of the patients that we have seen in our clinic are women, and the reason is that it's a filtered through type of effect that if men are not being tested, then they do not get seen in the clinics, and therefore we don't know what happens with them. So it's an ongoing challenge, and there are various strategies that are being employed to ensure that men can get tested, and one of the other important strategies that have been that people are trying to implement is that when women come for PMTCT, when they are tested during pregnancy, that they bring their spouses as well, so that they get tested and get engaged into care. I think it's a process. It will take time, but I believe we'll get there. Thank you.
So thank you.
Thank you very much. I want to congratulate all presenters, and I have a question for Alison Carter regarding the very high rates in women from First Nations. In 5 minutes, you didn't have a lot of time to elaborate, but I wonder if you could tell us a little bit more about these women and what are their causes of death.
Thank you for your really important question. The root cause of inequities in health outcomes, including mortality, between Indigenous women and other women in our cohort, is racism. Canada has a tremendously awful history of treatment towards Indigenous people, and I think that legacy continues today. We see it in our mortality data, and we also recently saw it in a paper that we published in JADES showing the cascade of HIV care. And it actually wasn't women, so we looked at both racial identity and then also racism, and it wasn't the racial identity variable that came out as significant in terms of inequities in cascade outcomes. It was racism. So I think, you know, in epidemiology and biomedicine, we tend to look at individual level risk factors when in fact it's much more structural.
Thank you.
Good afternoon. Mike St. Louis from CDC, USA CDC, and PEPFAR. And one very nice set of presentations, great lineup. But I hate to sort of rain on the parade, but I'm impressed at the bad things I'm seeing here. You know, I'm impressed with the data from Europe and Africa and other places that I don't know how far back you were going, but the CD4 counts that you were reporting on for women across all these continents were mostly below 200, barely above 200 in North America and Europe. In England, in London, you mentioned there's only 80% of patients were on ART, and the average age of the average survival age was 56, I think, if I remember it right. You know, that's not normal. We're not at the place where the rest of the population is living, and you know, in South Africa, the rates of mortality and particularly in men were pretty shocking, sort of currently. With all the justifiable excitement about the advances we've made with respect to reaching coverage, higher levels of coverage, and so on. I thought I was going to get better news here at our session on mortality. I'm not. I'm not feeling it. So I wonder if you can reflect on some of those and if there's actually better news than what I appreciated from the presentations.
So anyone wants to respond to that? Maybe it's not a question, but a comment.
Yeah, I'll comment. I don't have better news. It breaks my heart when I think about the women in our study who've passed away. And the funding cuts in our country, as I'm sure they are across the board, are awful. I think our policymakers think we characterize HIV as this chronic, livable, manageable condition. And so we're seeing funding cuts. And in my analyses, you see that it's not HIV clinical factors that are predicting mortality. It's social determinants of health. It's, you know, things like income and housing and, you know, violence and depression and substance use. And we should be funding services to address those. And until we do, the data is not going to get any better.
Hello, Mukhtar Ali, Vanderbilt University Medical Center. I have a question for the hepatitis C presenter. We know direct-acting antivirals have transformed Hep C treatment over the past few years. In the U.S., in 2011, the FDA pretty much gave the first approvals for the DAAs at that time. So I don't know if what impact have direct-acting antivirals have had on the mortality trends that you showed. At least one of your cohorts, the 2008 to 2014, most likely where probably had access to antivirals. Thank you.
Thank you for the question. We expect this. We expect that the AA have a strong impact, but this data was collected before these drugs were introduced, because it's just data until 2014. So in Europe, they were just started to be spread. So I don't think that the AA had an impact in our trends, but of course we expect that the picture nowadays is completely different regarding and among hepatitis C co-infected subjects.
Hi, my name is Ikwo Obo. I'm from CDC Atlanta, and my question is from Tene regarding the ability to ascertain mortality data in Africa. I mean, the composition of the panel certainly shows that some of those challenges. And so I wanted to ask, what factors made it possible for your hospital to be able to get this data? Because very frequently in Africa, we say people died from a brief illness.
Thank you. That is a real challenge that we faced in our study, and as I stated, that this was a retrospective study. So, in fact, we had a team of 2 doctors who went through the records. For some of the patients, we had documented death certificates that showed the cause of death. For a lot of patients, really, it had to be retrospective post-mortem from the patient data. So it is not as rosy. Our clinic is not that different, but the thing is, at least we collect routine data. We have an EMR, so we have a pretty good idea of what is happening with our patients, and it is easy to retrieve that data and use it for study purposes. I hope that answers the question.
So maybe a follow-up question to that one. The causes of death in your study, were they determined by what the clinicians recorded in the file, or were they determined by lab diagnosis or other criteria?
Both, or all. I don't know. I can't say both. So it is the clinic, as patients are being seen, their clinic records are all entered into the same electronic medical record. So the lab data, histology data, and even the data that is collected during an actual visit by the clinician is all recorded in the database. So this was all used to determine the causes of death.
Okay, thank you.
Thank you. I was really pleased to see a session on mortality this year. But an interesting observation is that even though there are 1 million HIV-related deaths estimated last year, and we do lots of studies of mortality, as researchers were only interested in if somebody died and not how they died. The new UHC goals state that everybody should have access to affordable palliative care. In the 6 presentations, nobody talked about how people die, but only if they die. So I'm wondering what that's about. I can't find an abstract here in the whole conference about palliative and end-of-life care, quality of death. I'd like to hear from the panel, why is that? Why aren't we addressing how people die and quality of death when it's a fundamental human right?
Thank you for that. As you know, we need people from those disciplines to be attending these. It's always been initially looking at what are the high very, very big indicators that we need to aim for. And as you're part of the group, the London Audit Group, as we're looking into deaths more closely, we find that dignity of deaths and having a life plan is really, really important. And you're part of that work, and perhaps you could talk about what happens in London a little bit. And you're quite right. I think some of the challenges over these AIDS conferences has been to just get over the very big numbers of just the shock of how many people, and that's what we presented here. But as we're getting into a new human rights framework, and we're talking about legal and barriers and other things, I think equally palliative care is one of those areas that's been very neglected in these conferences. Completely agree with you.
I think there's another question. Yes.
My name is Geraldine Dominguez. I am from the National Cancer Institute at NIH, and I actually have a very specific question to the Zimbabwe presentation. I was just very surprised to see in the data that you presented for the last period that non-Hodgkin's lymphoma was a significant cause of death, but never, you didn't mention KS. And I know in Zimbabwe there is a lot of KS, and we're actually we have a presentation here about a trial that was done. So were the KS deaths lumped into AIDS, or do you know how many had KS and died from KS? That's my first question. My second question is, do you know if any of your non-Hodgkin lymphoma patients received treatment at all?
KS was added to a broader group called malignancies in the earlier years. Whether it is still an important cause of death or amongst the top 10, it was not part of the top 10, because here I only listed the top 10 causes of mortality through the periods. During the presentation, I also mentioned that we are a referral clinic at Newlands, and our criteria for admitting patients into our cohort changes over time. And during the period 2015 to 2016, we in fact deliberately started to admit patients into our cohort who were diagnosed with some kind of cancer, because we had a particular fund that could assist those patients. And that is, in fact, I believe it's a reason why we saw non-Hodgkin's lymphoma adding to or making it or being in the top 10 causes of death in that last period. I hope that answers the question. Whether or not they were treated, I'm not the best. They were treated. Yeah, the doctor says they were treated, so they were treated.
All right, let's have the last question. Still have 2 minutes.
No, I just noted that there is still a little bit of time, and I wanted to return to my earlier point. I am baffled by the fact that, you know, these 40% of TB being the cause of 40% of people living with HIV dying. It's a preventable death. We had the TB 2018 pre-conference here on Sunday. It's 2 interventions that are needed. One is preventing TB amongst people living with HIV, which is a relatively low-cost intervention that is nowhere near being scaled up the way it should be. Secondly, to screen people on ART continuously for TB during their lifetime of treatment is essential, and that alone can reduce just the screening can reduce that mortality by 50%, even without any new tools. So it begs the question, and I'm just, why is it not happening in the HIV programs as much as it should? PEPFAR is taking it on in its COPS process this year, but a challenge, you know, we need to name the cause. We know what to do. It can be done with current technologies. Just putting it again there because there was still time.
Yeah. However, I think you'll notice that most of this data is old, and perhaps, we've increased the coverage for IPT, for example, in the last few years. So perhaps next year, or maybe if we look at the most recent data, there will be an improvement. But I think you have a great point about TB screening and integration of those programs. Yes.
Yeah, I have a question, and it could be to anybody. I mean, we haven't raised the issue of stigma and the issue of actually still not really writing on the birth certificate what really the indication for the cause of death is. And I wondered whether or not anyone has an idea of any progress in really working towards getting accurate birth certificates, particularly in South Africa and places where we require that information much better.
So in South Africa, what we've done with the challenge of the way doctors actually fill the death notification forms in, but not the birth certificate, the death notification form, we've actually started a training where we train the doctors about ICD-10 and how it's actually they're legally bound to actually report HIV as a cause of death and not hide it away in the AIDS indicator conditions. So we've started that training, and I think our Department of Health is going to take it further, and our National Statistics Office.
So have you got good results so far?
So basically it was done in 2012, and I don't know if you were here when I did the presentation, our NBD study went up to 2012. So our third NBD study will actually be able to see the difference in the number of deaths that are reported to HIV post that training.
Does it require community engagement as well? Because the pressure would be there on clinicians not to be reporting that from families, right?
So the training was focused on doctors in the districts, and I didn't have community engagement.
Mainly it's the doctors. I mean, if I remember, we always used to write death due to cardiac arrest. At least.
You can't do anything with that.
So mainly it's the health workers, if you can. It's always cardiac arrest. Okay, thank you to everyone and to our speakers. Let's appreciate them.